So we have our next guest. It's Erika Castro from Lausanne. She is an internal and addiction medicine specialist with a cabinet in Lausanne. She received her degree in Venezuela, and she has completed a Master's of Science and a PhD in Brazil. Throughout her career, she worked with vulnerable patient populations such as sex workers and people using drugs, and her current interest lies in testing and treatment strategies for patients with hepatitis C and health for people that use drugs. She initiated the initiative of a hepatitis C virtual clinic. Sounds really interesting. I would like to hear more about that. And it's a project for micro-eliminating hepatitis C and in the canton of Vaud. She is the co-founder of the cohort SAMSU, a unique cohort that is dedicated to the health of people who use drugs. And that's what she will talk about, the monitoring of infectious diseases in a key group in this SAMSU cohort, about the characteristics of this cohort, as I understand, and what it takes for people with hepatitis to be detected and promptly treated. Thank you so much for coming here.
Thank you for the very kind presentation. Actually, as I'm smaller than the other speakers, I will not really use this screen a lot, but rather this one. And I understand monitoring is a bad word just after the talk of Professor Tanner, in the sense of what it can lead to or mean, but the intention was really to present you the SAMSU core study on behalf of all my colleagues of SAMSU. These are my disclosures, and these are our sponsors, current and past sponsors of SAMSU, to whom we are also grateful. And the story begins at Zurich in 2011, not among the founder group. Actually, there are two of them with us today, Claude Scheidegger and Philippe Brugman. And it was a challenge of this group of internists and infectiologists and addiction medicine doctors to start a Swiss Association for the Medical Management in Substance Users, with the idea of improving healthcare for people who use drugs in Switzerland. And thanks to the acceptance of Olivier Verly, peer and member of the scientific committee of SAMSU, I will refer sometimes to this group as with the abbreviation that you will see later in the slides. In order to achieve this very, I would say, important objective, it was clear that a way to do it was to create a prospective cohort study. And the idea was to be able to recruit in the different centers to enroll volunteers which would need to be older than 18 years and being at least 1 day on opioid agonist therapy, and providing a written informed consent to be part of this core study. So after 10 years performing this cohort, which you will be discovering in the following slides, we still are very strong with the commitment of becoming a reference cohort for medical and public health evidence-based data among people who use drugs. And I hope that by the end of the 20 minutes we're going to be together, I can convince you that we have that we are in the good way to get there. So back in 2012, more or less on the time that SAMSU started, in Switzerland, as elsewhere, people who use drugs and injected drugs were actually in the core of this HCV burden. And here, of course, what we see here is data that refers to people which are co-infected with HIV, because it's the Swiss HIV cohort. But I just wanted to go back in time to where we were, even within this data of the HIV cohort and the importance of this key population. Very early also, at the same time, we had the crossover with the direct-acting antivirals that arrived and gave us a huge horizon and a change in terms of treatment of hepatitis C. We also knew that we had a lot of work in front of us in order to translate this tools of treatment and deliver them to some particular groups as people who use drugs. And the reason, the main reason to it is that we had to create models and we had to create strategies to have integrated care services. But fortunately, in Switzerland, we had already quite some good examples of that, and actually you can see a very good story on integrated care services at this video that is shown at YouTube, and it's carried out by different people delivering this kind of services in adult. I think it's really nice for understanding how we can roll this up, but there are many other examples today as well. And where do we stand today? I mean, there's a lot of things going on in 2024 in Switzerland in terms of our court. We are, I think, in an interesting moment. You can see here on the right side the cantons where there is a diacetylmorphine-assisted treatment system. And with the add of the Ticino, the Samsu court is also very active in the same places, which makes of it not only a court that is present throughout the country, but also, I would say, region-wide, because it also includes the Ticino. So the work that we are doing on a daily basis when we meet the patients that consent to be part of the court is filling up this online recording system. So this is one example of a baseline case report form, which has basically demographics on it, and obviously we need to record also the consent inform data. And just to give you a little bit of flavor of what it's like, there are other 13 chapters that we can cover during a follow-up visit. So we have also several diagnostic procedures that we record concretely. In the case of hepatitis C, it could also be liver fibrosis data, for instance, previous treatments or current treatments. There is also other comorbidities and other informations about other transmissible diseases, vaccinations. And again, here it's just an example of, for instance, also alcohol and drug use. Here again, more about different other health conditions. And obviously, we do record plenty of information in terms of HIV and viral hepatitis, particularly HCV. viral infection. That takes us now to show you a very short overview of the core characteristics today. So sorry, I want to go back here. Oops. Right. Just here to mention that our sort of CTU is based in Basel. So that's where we have all this information that is being collected. And this is how it looked in September. So we had 1,453 persons that were enrolled, and with a average age of 43 years, and the majority were men. The vast majority were also still on substitution treatment, as you can see, roughly 97%. And historically, it is a cohort. This is our information at baseline. So it is a cohort with a retention of basically 9% of HIV positive serostatus. And for hepatitis C, it's 58%, and a high amount within, like we know from elsewhere, it's people who harbor or harbored once a chronic hepatitis C infection, so nearly 80% of them. I will be telling you more about the treatment in the following slides. Here, what I like to show here and stress is the fact that ever since the beginning, since 2014, the cohort has been expanding and really growing in a good way. It's true that our main contributors are at Aarau and Zurich, so these are the leader settings. And are followed then by Lugano, and all the other groups are coming just after. In what does differentiate us from other existing and very well doing cohorts, as the Swiss HIV cohort and the Swiss ACV cohort study, is that the SAMSU cohort does not only record or only includes people who use drugs with HIV and or hepatitis C infection, but it's really looking to people who use drugs broadly and is interested in monitoring and following and looking what happens with their health over time. In terms of follow-ups, it's also a good time, because now we are farther than 3,000 follow-ups. So that means that at least once a year, people have this follow-up meeting where we can reassess all the transmissible diseases information, chronic diseases, and other things as well. Also social and demographic information. So indirectly, we could, in a way, also follow quality of life somehow. And currently, according to this number we had here in September, we expect that by the end of this year, so in a few weeks, we will be again reaching at least 500 follow-ups for 2024. Here's an interesting data that was prepared by our colleague Andrea Bregenzer, showing a little bit the evolution of the ACV treatments, and we can see that even prior to the cohort, of course, there were a number of participants that had been treated in the interferon-based era, and that after being part of the court as well, there has been a big expansion of this intensity of treatment, and it's obviously very much related to the fact that we have this interferon-free direct-acting antivirals that facilitates a lot treatment, and that has allowed us to go to a very high intensity of treatments, and 2017 is a very important year for that, because also it was the year that this restriction of advanced liver fibrosis was required in order to have access to a reimbursed treatment. So we have seen quite a lot of treatment over these years, and later on it has been a little bit dropping to the levels we had at the beginning of the interferon-free era. Since 2015, so the first year we started the cohort, we have been releasing data. The structure we have today includes also a mandated researcher, which is our principal investigator, Andrea Bregenzer, and she does a big part of this analysis that I will be presenting here briefly, just to give you an idea. So we are very committed to this international network on health and hepatitis of substance users. It's a conference that takes place every year. This year it was in Athens, and it's an amazing place for those of you that are interested in this domain. I can only recommend you to go there. You learn a lot, and it's a very inspiring moment with a lot of people that share our dreams and our objectives in the field. And also a lot of peers and social workers, so it's a very, it's a real world where we would like to work all the time. And in this very good conference, we do present on yearly basis data, and so you will see that there are quite a lot of titles of different abstracts that have been accepted there and that are about hepatitis C, but we have also looked into other subjects as aging, for instance, with addiction. And in 2022, there was a main publication at Swiss Medical Weekly in terms of where we were with the hepatitis C virus elimination in the SAMS cohort. We have also looked at late presentation, and you will see later here another slide talking about late presentation again this year. And we have also looked to other issues as mental disorders and hepatitis C within the people that are part of the cohort, followed at the cohort. Of course, another domain that is important for us is HIV and HCV co-infection among the patients in the cohort. We have also showed how there has been no new HIV infection over the past 8 years within the members of the cohort. And we also have studied about reinfections, which are extremely low, but of course happen because that's something I want to stress also. If we don't have reinfections when we work with people who use drugs, then we don't really work with people who use drugs, because this can happen. It's a risk and it's an exposure that can remain there. So it is not at all a demonstration that something is wrong with the system. It's part of the dynamics in this population that can still again be exposed. And we have also looked to liver cirrhosis and also other issues as metabolic problems within the patients of the cohort. And as I said just earlier, unfortunately, we have still detected ACV late presentation among patients in the cohort, and as I think Andrea was very well concluding here, it's striking because we are in the times of unrestricted access to direct-acting antivirals, and we still find this late diagnosis and late treatment of chronic hepatitis C. So that shows, I think, the size of the challenges we still have to overcome and to work, keep on working on. On the other hand, as I tried to show you in the beginning with the different case report forms, the cohort looks to many different health issues, and the idea is that we could, of course, explore many other questions and many other interesting interactions among different health conditions. For instance, some of them are listed here, and one I think it's very important is I was putting here HIV, HCV treatment as prevention, but it could go farther because we are today at the Symposium of Viral Hepatitis, so it should also include other viral hepatitis as well, and it is on the pipeline. We hope for the next year we will have interesting data to share concerning hepatitis B as well within the patients that are followed in the cohort, and where we are and how are we doing with our model of care in terms of hepatitis C as well. And there are these other questions which are less medical but so important, like life quality. I think a cohort is also important for that, to see if, to get hints on how we can improve people's life quality. One way, of course, we always think as doctors is medical conditions, but there's a lot more than that to get there. So as a cohort group, we have plenty of challenges. Being representativeness, that's one thing we want to get better. We want to be better in terms of regional-wide representativeness. There is a lot of work to do in the Romandie, and particularly to be stronger and to have more presence within the court. Because also regions, and we spoke earlier about health systems, so health systems in the cantonal level are also different, and challenges are also different, and I think this is something that if we are more present, the different regions, we can better explore and get interesting support throughout the regions, learn from each other. Syndemics research, I think we start to have a volume also of data that allows to do more of this, and not only just the traditional one disease like Professor Tanner was saying before is very interesting. We do a very simplistic approach, right? And it's all about one target, and it's, again, we get far from the population. So it will be interesting that we start to go into this more complex questions of research, analysis. And I think the hardest one when I get there is always sustainability. As a court, we need to find a way to become more sustainable over time, so that we can really use our senses and our skills to do this more complex research. And I think, I don't know what happened. Oh, yeah. So this is a small overview I could prepare for the time we have in terms of where we are, what we have achieved in this first 10 years. We're still learning a lot, and we're always questioning us a lot about how to do better. And I think that's the only way to go. And one thing that is for sure a fact is that when you go to do the literature and find other cohort studies in people who use drugs, the nearest one that comes across is this Sweden study, which is very nice. Was now it's from 2021, the publication, and it was basically a short follow-up for a few years in people who use drugs that were incarcerated. And this is the nearest that comes to what we are performing here with SAMSU, which I think is for sure showing the complexity of having a court like SAMSU. And that's why I really think it's unique in its kind, and it's a good opportunity for us here in Switzerland to learn more and also to be this reference court for others, to inspire others as well. So having said this, I like to just say thank you for your attention, and with the photos of all the other colleagues that are part of this court adventure and group. Thank you.
Thank you very much. Thank you so much. We'll have a moment for questions. Before we take a break, we have 5 minutes or so to ask questions for Erika, Castro, or Marcel Tanner. You in the audience, do we have anybody in the online audience? Do you? Not yet. Okay. So do we have anybody in here that, I'm sure you have questions, must be, it has been so interesting. Any questions, or are you so tired, need a cup of coffee? Mm-hmm. Okay, here we go.
I have a question for Erika. Why are there so big differences in the heroin treatment in Switzerland? It's a federal law to you can have heroin, but there are so many cantons where you can't get it. What is the reason for that?
I'm not sure I can fully answer the question, because there's, I think, a lot of cantonal level reasons for that, and in a way it could be also sometimes on policies of each canton. I can only speak for Vaud. I know that in Canton Vaud we were the later comers to the system, and I can say that in Canton Vaud, I know that it was voted 2 times and 2 times rejected by the population to have a different type of strategies, like for instance, I didn't mention it fully, but to have consumption rooms. It was 2 times refused. Today, we have 2 consumption big rooms, fortunately. And yes, I think it is very much related to each canton's history and life, and the domain itself, how it has evolved. Many of us are sure that Ticino will join the others in a near future to have also the diacetylmorphine service.
Okay, thank you. Any more questions before we break? Yes, do you have a question for yourself?
I don't have a question, but an addition to when Erika started, she was a little with the word monitoring. You know, monitoring is fully okay if it is done in the spirit of surveillance. This is what actually people should have. Monitoring in the spirit of hunter-gatherer and just collecting data. That's what I criticize. But the spirit of monitoring, that was actually our initial biggest problem, to make it clear, particularly for the affluent society health system, that and also the donors, they are so happy with M&D, and we're never questioning. And if you go to the countries that really have to do it, that are poorer, low and middle income countries, they actually suffer a lot on this stupid, I use the word stupid, monitoring, that actually are just created to satisfy donors and to satisfy data banks, but not for public health action. I mean, just as an example again on malaria, to get money from the Global Fund, you have to do the malaria indicator survey, and you have to report every month on about 400 or 500 indicators. And this is really total nonsense, because many of these indicators are not useful for public health action. And you use the best people in these countries to do these, filling these spreadsheets. I would rather say spreadsheet, because it cannot be used.
Thank you very much. I think that's a good word to go out and have a cup of coffee after that.